Welcome everyone to our July Manna webinar. I'll just wait a minute or two as people start joining. Well, it looks like we've got a good few people have joined us for our webinar, so we might get underway, and if more people join us as we go, that's great. So good afternoon, everyone, and welcome to our July edition of the Manna webinar. Our topic today is addictions and mental health in rural, regional and remote Australia. My name's David Duncan. I'll be moderating today's session. I'm a PhD student at the University of the Sunshine Coast, and I'm fortunate enough to have a Manna Institute scholarship to support my research. I'd like to start today's webinar with an acknowledgement of country. So Manna Institute respectfully acknowledges the First Nations people as the continuing custodians of this continent and pays respect to elders past, present and emerging. The Institute honours their rich cultural heritage, beliefs and enduring relationship to the lands and communities in which we all live, learn and work. Today I come to you from Gubbi Gubbi country, and please feel free to mention where you are joining us today in the chat. So for those of you that aren't familiar with the Manna Institute, or you're joining us for the first time, Manna Institute is a virtual institute formed by RUN, the Regional Universities Network. There are 7 universities in the RUN: University of New England, which is our Manna's foundation member, Federation University, CQU, Charles Sturt University, Southern Cross University, University of Southern Queensland, where I'm based, and the University of Sunshine Coast, where I'm based, I should say, and the University of Southern Queensland. Always mixing the two of us up. Our foundation partners are Every Mind, Lifeline Direct, Lifeline Research Foundation, and the Centre for Mental Health Research at ANU. At Manna Institute, we have some of the leading researchers and industry partners who are working with rural, regional and remote Australian communities to improve their mental health and wellbeing. Manna supports meaningful research, fosters the development of professional workforces, and translate research findings into practical, place-based programs. So today's webinar will be another in-conversation format. The topic is addictions, focused primarily on alcohol and other drugs, and the impact on mental health in rural, regional and remote communities. Now, unfortunately, one of our presenters, Rachel Wallace, the Aboriginal Program Manager for the Network of Alcohol and Other Drugs Agency, is unable to join us today. Julaine will be presenting on some of Rachel's work. I'd like to acknowledge Rachel's dedication to this important topic and the work she does providing advice and guidance regarding culturally appropriate practice in this sector. So I'd like to welcome the 2 academics and researchers joining me today, Dr Julaine Allan and Professor Anthony Shakeshaft. Dr Julaine Allan is Associate Professor of Rural Mental Health and Addictions at Charles Sturt University. Julaine is also a senior researcher with us here at Manna Institute. Julaine specialises in mental health and addictions. She's worked with multidisciplinary, multi-site research teams for over 15 years on projects involving vulnerable populations and Aboriginal communities. Julaine specialises in practice-based research, focusing on healthcare for vulnerable groups, particularly people who use drugs. Julaine has extensive experience in intervention and implementation research in real-world settings. Professor Anthony Shakeshaft is an expert in health behaviour and health services research. He's currently Professor of Indigenous Health Services Research at the Poche Centre for Indigenous Health at the University of Queensland. Professor Shakeshaft has previously been Deputy Director of the National Drug and Alcohol Research Centre at the University of New South Wales. His primary interest is in partnering with health services, communities and governments to co-design, implement and evaluate the impact of services that are both best evidence and highly adaptive to the characteristics of different service delivery ecosystems. Once again, welcome to you both. So for our audience, if you have any queries or questions at any time, please pop them into the Q&A section, or feel free to ask them at the end of our discussion today when we'll stop the recording. So Julaine, if I could go to you first, from your research, can you set the scene for us on the impact of drugs and alcohol in rural, regional and remote communities, and how this affects mental health services and other service delivery?
Wow, that's a really big question. Thank you, David, and thanks for the opportunity to talk to everyone today, and from Wiradjuri country, where it's 3 or 4 degrees where I am. So yeah, we're freezing. I'm going to give you a couple of examples of research that I've done over the years in drug and alcohol, and how connections with practice and with clinicians are really a really important part of making rural and remote drug and alcohol services and other sorts of services relevant to the communities that we live in. So I worked for maybe 15 years in a non-government organisation with research responsibilities and clinical responsibilities. And that was a really great way to have practical and practice-based insights into the sort of research support that drug and alcohol clinicians need. For example, remember the ice epidemic, maybe 2015, 2016, when ice was the favourite topic of the media in Australia. I looked at the routine data that was collected nationally by drug and alcohol services to look at changes in the treatment population as a result of methamphetamine use. So, for example, the media says there's an ice epidemic, but what does that mean for people presenting to drug and alcohol services? And as it turned out, what it meant was that instead of older men with alcohol problems, the sorts of people who were presenting more frequently were younger women using methamphetamine and experiencing problems with their methamphetamine dependence. And I really think that sort of information indicates the need for a change in practice and a change in the way services are delivered according to the people who are using them. So younger women with families, different stage of life, certainly have different concerns and priorities than older men who with alcohol problems and perhaps longer term chronic conditions as a result of those alcohol problems. So that's one way that you can use routine data, the way research can inform practice and respond, I guess, to changes that we're hearing about and validating, is it real? Is what we're hearing in the media real in relation to people's drug and alcohol use in rural Australia? The other thing that I learned or have learned across that time is that drug and alcohol use cuts across all of the other health and social community sectors that we have. For example, domestic violence, child protection, mental health. Substance use is a problem that affects all of those areas. People will say things like, if only that domestic violence perpetrator, man that commits domestic violence, didn't drink, then he wouldn't be aggressive to his partner when he's alcohol affected. So he needs to get his alcohol use. So he needs to go to treatment to get his drug use sorted out. We're still hearing that mental health services are saying that person has a substance problem, they need to sort that out before they can come to us and get their mental illness treated. The drug and alcohol treatment has to come first. And then drug and alcohol services are left with people that have serious unaddressed mental health conditions that are too difficult for them to manage. So substance use cuts across all of those areas, and a lack of knowledge about the scope of substance use or the wide range of patterns and practices that people, in the way that people use drugs really affects their ability to participate in services. One, I guess, practical example of how we can address that in research is that I'm doing a project about cognitive remediation therapy in schizophrenia. Now, usually people would be excluded from cognitive remediation therapy if they report that they have a history of substance use. And a history of substance use can be like broad. For example, everybody will use a substance at one point or other in their lives, sometimes all the time. It doesn't mean that they necessarily have a problem or a dependence on that substance. So having a background in substance use treatment and research means that I can say to the research team on this project, at what point are we going to exclude people from access to this therapy because of their substance use? And and what's the level that makes the drugs that they use mean that they're ineligible? So rather than just having a blanket ban on everybody that ever reports using some sort of drug or alcohol can't come into this therapy, we can be more nuanced and have a better understanding of how that substance use might affect their ability to participate. So I think those sorts of practice and clinical issues that drug and alcohol treatment providers understand are really important for researchers to understand, and that we need that really good connection between research and practice to make our research relevant to the practitioners and to make the practice relevant to the research. One final example that I'll give you before I finish my bit in this section is about the Family Empowerment Project. Now, Anthony and I started work together as researching support for family members that have somebody affected by drugs or alcohol, like back in 2010 or 11 or 12, quite a while ago now, because we were hearing from communities that there was a need for family support around their relative or loved one's drug and alcohol use. Now, we've had a few different goes at implementing what's called the Community Reinforcement and Family Training Program, or CRAFT for short. It's a program based in cognitive behavioural therapy and motivational interviewing that comes from the States. And it's quite... it has a very strong evidence base across research, dating back to the 1970s, but it's not available in Australia. We don't have a history of training people in it here. We don't have a history of offering it as support to family members. So the research project that I'm doing with my colleagues, Nicole Snowden and Heidi Gray, is randomising people into the Family Empowerment Program. They either go straight into the program or they're on a wait list for 6 weeks. We trained clinical psychologists in private practice to deliver the program, and they're the ones who are providing the program to people who come to us for support. Liz from the Manna Institute will put up the flyer to the program so that if anybody wants some further information, or they have somebody who they think needs support from this program, you can apply using the QR code. But it's an online program for rural people. We've had 110 people screened since January this year, and Heidi started collecting the qualitative feedback. And what we're hearing very clearly is that drug and alcohol services are not available in rural areas, and particularly not for family members. So while we think about carers as an important group to understand the burdens that they carry or their experiences, or that they need extra help, if they're caring for children with a disability or caring for somebody with a mental illness, when it comes to a drug and alcohol problem, family members are very often blamed. It's their fault that their child, partner, whoever has that drug and alcohol problem, or that child or partner is hopeless and should be abandoned, and that their caring for them is somehow, you know, a misguided or misjudged activity. So carers of people with drug and alcohol problems are extra stigmatized, and we've found that they really value the support of the program, and they particularly value the structured nature of the psychological therapies that are offered. And they've provided, you know, quite detailed information about the changes that they've made in response to that therapy. So it's a bit different to attending a support group where you share your feelings and experiences with other people in a similar situation. Instead, this is a therapy that's about behaviour change and, you know, making a difference in people's well-being. So very excited about how that's going. But as a researcher, our you know, like our big question now is where to next. We're going to finish the recruitment for the Family Empowerment Program. We'll hopefully build on the evidence base, the global evidence base for this particular program. But where are we going to take the program next, and how are we going to make it more accessible and more available to people in rural Australia? So that research question, you know, like that's just at the end of every project. That's what researchers are talking about, where to next. It never ends. But that's it. Speaking of ending, that's it for me, for my bit for now.
Thank you, Julaine. That was very informative and insightful. And I invite anyone, if they've got any questions for Julaine on any of that content, to pop it in the Q&A section. You'll see down the bottom of your Zoom screen. While we're waiting, if you're happy for one follow-up question from me, Julaine, while we're waiting to see. I think you mentioned at the start the barriers to people if they've got drug and alcohol issues to receiving mental health support from services. In your research, have you come across any examples where there's co-location of both drug and alcohol and mental health services in communities, or do they still remain siloed, a separate service?
Yeah, well, that's, I mean, it's very variable, and certainly in the public health system, like, you know, the public health system state-based, and in New South Wales, these services come together and come apart again, and come together and come apart over the years. Anthony and I actually shared a PhD student, Kath Foley, who her PhD was on how to actually provide integrated care for mental health and substance treatment at the same time, because while there's a lot of talk about it, it's always the details, you know, it's always the practicalities of how you actually do the day-to-day that get in the way of, you know, the services coming together. So Kath planned and implemented an integrated drug and alcohol program within a mental health rehabilitation unit. Now, hopefully that still exists, but yeah, I mean, I think it's pretty varied. And people will know, you know, when they work with their local services about how that happens in their patch. And obviously it would be ideal if services were integrated, but the detail is difficult. Did you want to add something about Kath's project, Anthony?
Oh, really just to reinforce, thanks, Julaine, really just to reinforce that, you know, that's a really interesting one, I think, because as long as I've been working in drug and alcohol, you know, everyone's talked about better integration between drug and alcohol and mental health. And it just feels like I was going to say it feels like a unicorn, but when you kind of start working in it, it's really interesting because it's conceptually straightforward. Like I don't know anyone who doesn't think better integration of mental health and drug and alcohol is a good idea, but no one can do it. So it's a really interesting, you know, I think it's just about the way health services are structured and delivered that makes it, you know, almost impossible to routinely develop and deliver integrated care. So that's you know, I'm always really interested in those problems that are, you know, not conceptually difficult, but they're in practice, they're really kind of hard to implement.
I'm probably a little bit biased, or a lot biased even, but I think the drug and alcohol services have made huge strides in understanding the mental health conditions of people that come through their door and working with that. whereas mental health services haven't taken on board harm reduction and how to treat drug and alcohol problems as well. And I hope I'm not going to get shot for that. Yeah, but yeah, I think that's the case.
Thank you both for that. And yeah, I agree with Anthony. It seems straightforward, but harder to put into practice, particularly with federal, state, and different levels of health services. Yeah. Question from the audience for you, I assume, Julaine. From the qualitative data, is there any indication that craft helps the person with drug or alcohol problems?
Well, I didn't check that with Heidi this morning when I was getting ready for this presentation. Certainly, the studies that have been done in the past, and mostly in the USA, found that people, the relative with the drug and alcohol problem was much more likely to enter treatment than for people who didn't do craft. So, you know, the sort of numbers that are thrown around are a 75% success rate of people entering treatment for whose family members have done the craft program, which is pretty good.
All right. One more question. Yes, another audience member question. Is the likelihood of mental health issues higher for people with drug and alcohol problems than those without?
It's a little bit of a chicken and an egg scenario, but, you know, there's certainly definite mental health problems associated with different types of drug use. Like people with chronic alcohol use are more likely to experience depression. There's a definite relationship between episodes of psychosis and regular methamphetamine use. So, yeah, I mean, there is a connection between frequent substance use and specific mental health conditions that will resolve once the person's drug use reduces. But there's also a link between people having a drug and alcohol problem because of their mental health concerns, you know, using alcohol because of their anxiety, that sort of thing. So yeah, very chicken and egg.
All right. Well, let's move on. I have one more question coming through. Sorry, just quickly. What are your thoughts on the use of peer workers in the alcohol and drugs space?
Well, I think that, you know, that the role of a peer worker in all sorts of different settings is very useful because they bring that lived experience. But I'm a little bit, as a, you know, like as a social worker and social work being my professional background, a little bit concerned that people are undervalued as peer workers. And in fact, they're doing the same job as anybody else, but they've got this label that says they're somehow lesser or less able. So that's one of my concerns about peer workers. Yeah, but perhaps that's a different topic for another day.
All right, well, we might move on. Now, Julaine, you're kindly going to be presenting some of Rachel's content, looking at culturally sensitive services and both for workforce and for those that are consumers of drug and alcohol and mental health services. So if you're happy to move on to that, and I'll throw back to you.
Sure, thank you. Let me just organise myself with Rachel's presentation, which I need to share my screen. After all of these years, you'd think it'd be easy. All right, I think if I share this one, I hope you can you see the presentation?
Yeah, see the presentation. It's in presenter mode at the moment.
So this screen where my cursor is?
No, we're still seeing your presenter mode with the two slides.
Let's try this one.
That's better. Yep, that's good.
Send somebody to run in to help me. Alrighty, so this is actually, I'm just going to talk about a project that Anthony, Rachel and I did together along with our colleagues Alex and Sarah Farmbach from the National Drug and Alcohol Research Centre at UNSW. Just going to jump forward a couple of slides. Okay, so Rachel and I were working together in a drug and alcohol service, like mainstream, as we refer to it, not an Aboriginal community controlled health service. And there's a lot of Aboriginal and Torres Strait Islander people coming to use that service. And I guess Rachel's perspective was that there's a lot of reasons for people to come to mainstream services rather than community controlled services because, privacy, confidentiality, they might know the people at the Aboriginal health services. And Rachel was very passionate about ensuring that cultural responsiveness of mainstream services should be good because we know that there's lots of racism in the Australian health system. But we also know that there was also a lot of people wanting to improve care for Aboriginal and Torres Strait Islander people, but not really knowing how to do it. So what we did was developed a guideline, and Liz will put the link to the guidelines, which are freely available into the chat so that anybody can see them. But Rachel undertook a consultation process with elders groups and clients to look at what were the things that they thought were needed to be changed in care that they'd been provided. We did a literature review to synthesise the existing guidelines on how to work with Aboriginal and Torres Strait Islander people in Australia. And we stopped, I think Rachel collected about 130 different sets of guidelines, and we just stopped in the end because they were all saying very similar things. And it was about, it was about at that point that we're like, we can create more guidelines. We can synthesize these guidelines, and we can create something that's another set of guidelines for people in the drug and alcohol treatment sector, but are they going to even use them? Like, there was already alcohol guidelines, methamphetamine guidelines. We looked at different sectors, including childcare and child settings, about the guidelines that they use to support their work with Aboriginal people. So we decided, along with Anthony and Sarah at NDARC, that we would do this process of developing the guidelines, but then we really had to make it a research project and evaluate whether it even made any difference. It wasn't just enough to have some guidelines and send them out there. We needed to have a process to support people to actually implement the information in the guidelines and then evaluate how they went with it. So the Network of Alcohol and Other Drugs Agencies, or NADA, along with 6 New South Wales primary health networks, supported the project financially. We had a project advisory group, and we had the research team, and we had 15 participating drug and alcohol treatment services that agreed that they would participate in this project that included implementing the guidelines and being evaluated on their practice changes. So the guidelines themselves, and as I said, Liz will put the link to them in the chat, were based on the principles of choice, respect, and person-centred care. And choice is really around that Aboriginal and Torres Strait Islander people get to choose the service that they want to go to. They don't get funneled into one, simply because that's where people think they should go. Respect for people's decisions, and of course person-centred care is fairly self-explanatory. So the guideline themes, there was 6. It was around service delivery and how that service was delivered. It was around bringing in the local Aboriginal community, their voice and their history into the service, the organisational responsibilities in delivering care to Aboriginal and Torres Strait Islander people, such as in, you know, how is staff recruited, how are staff supported, that sort of thing. Creating a welcoming environment for people coming into the service, engaging with Aboriginal workers and other Aboriginal and Torres Strait Islander services, and having staff who were trained and capable and supported and supervised to work with Aboriginal people. So those themes are aligned with the National Safety and Quality Health Service standards that healthcare services adhere to when they go through accreditation. Our 16 services were all over the state. You can see where those stars are there, are the ones that participated, and they were a really broad range of services. They included resi rehabs, day programs, centre-based counselling and support, outreach counselling and support, meaning, you know, the workers went out to see the people that they worked with, the clients, group work and phone support, and a couple of youth-specific services that ran groups and had individual counselling. Our evaluation questions were around the completion of the project, what the staff thought of it, you know, was it acceptable to them? And importantly, did the project change practice, and did the project change service use by Aboriginal people? We had qualitative data and quantitative data. So we developed an audit based on the guideline document, because we needed a way to assess the practice of each participating service. And so, yeah, we had an auditing process. So this is the implementation steps. We developed the guidelines. Then we did a baseline audit. So there was 21 action areas in the audit that were related to the guideline that had been developed. And we did auditing interviews with every participating service. For example, Rachel and I would go as the Aboriginal auditor. She would ask the questions about the different areas of practice, and I would take the notes in the audit. We'd provide the service with a report, including 3 suggested areas where they could make changes. We then invited services to a workshop where they did action planning and decided what they were going to change. And this is where I felt that the implementation was really embedded in the project, because in that workshop, people had to do a detailed plan about exactly what they were going to do in response to their audit criteria. So we didn't let people get away with, yes, we're going to hire more Aboriginal staff. Instead, they had to make a plan where they identified the position, they had a time frame for recruitment, they said who was going to do the recruitment, you know, really, really detailed plans about what they were going to change in practice. 3 months later, we went back and did a second audit to see what had happened, whether people had been able to implement the changes in the 3 areas that they wanted to. And then there was a data collection from the routine data, the minimum data set, to look at changes for the people receiving treatment in that service. The other thing we did was train 6 Aboriginal auditors to support the implementation of the guidelines. So obviously, if we're looking at practice in relation to Aboriginal and Torres Strait Islander people, then the people judging that practice have to be Aboriginal and Torres Strait Islander. So we trained up those 6 auditors, and then went back 2 years later for audit 3 to see what had happened. The research was a cluster randomised step wedge design, which meant that services were randomised according to the start date of their auditing and implementation process. And you can see there we had audit 1 is in the orange, audit 2 and audit 3. So we started in June 2019, went all the way through COVID and finished in July 2021. That's the services. I think we had a pretty good retention rate. We started with 15, we had 12 at audit 2 and we had 11 at audit 3. And all those 11 services gave us access to their minimum data. So when we looked at the acceptability, the staff reported that the project changed practices. They could describe the changes that they made. They could talk about, we used to do this, now we do that. And there was a lot of interest around the staff, from the staff around implementing different practices to improve their cultural responsiveness. We found at the workshops, Rachel and I found that people were very engaged. They wanted to make changes. They wanted to know how to do things differently so that they could improve their practice. They reported building skills and capacity around cultural competence, and that the audits and the reports that we gave them about this is what you've done well, this is what you could do better, really prompted change and gave them something to focus on instead of going, we're not so good at working with Aboriginal and Torres Strait Islander people. They had some very specific and clear steps that they could undertake to improve that practice. It's just that people like the workshops. That was the survey results. So here is the changes. So between audit 1 to 2, 10 of the 12 services increased their scores. So you can see that in this line here where things go up and down, we're looking for the ones that are going up. So in general, 10 services improved, 2 had no change. And between audit 2 to 3, 7 of the 11 participating services improved their scores again. 2 had no change and 2 decreased. So they didn't do so well by the time we got round to audit 3 2 years later. Oh. So what we didn't find were significant changes in the proportion of episodes of care provided to Aboriginal relative to non-Aboriginal clients. So that means that the number of episodes of care did not increase. We didn't find significant changes in the number of episodes of care provided to Aboriginal clients or the proportion of completed episodes of care. Now, it's a complicated result, this one, because changing practice in an organisation doesn't necessarily mean that more people are going to come to it. So what I think the important result is that we wanted people that did come to the service to be more likely to complete their episodes of care, which we didn't find a significant change in that. I think that there's a few reasons for that. Improving people's cultural responsiveness doesn't necessarily translate to increased service use by people, who are not in the service already. We might have needed more time to look at changes in data over time, and the MDS, like the data outcomes that we selected, may not be the most appropriate. Instead, it could have been that a patient-reported outcome measure or a patient-reported experience measure were a better option than simply counting numbers, in the routine data. So that study has been published. I don't know, Anthony, if you've got anything that you want to jump in on now about this project. No, you save it. Okay. One thing that did happen is that you know, I said, I'm just going to jump through this, is that people could describe changes that they made that they felt made a difference. But we did think about the expansion of the project to other services. So the idea of having an auditing process in the implementation of guidelines, to me, is a really solid way to influence practice. And it was taken up by another project run by the NADA, where they looked at cultural inclusion in alcohol and drug services in New South Wales. So they developed an audit using a co-design process around inclusion of culturally and linguistically diverse people in alcohol and other drug services, because 98% of people attending non-government drug and alcohol services are born in Australia. Very few people from overseas born reflected in that data set. So to improve cultural inclusion, that auditing process was taken up by another group of researchers and evaluated. So you can see that that's been published there in Drug and Alcohol Review. Yeah, so that is Rachel's presentation around the Aboriginal guidelines. I'll leave that there. Thanks, David.
Thanks, Julaine. And it's certainly, I think, a good example of working with communities, working with services and empowering services to be going through that audit process. And I liked how you said putting in sort of concrete actions at that workshop as part of that participatory process. I think many a time research can be coming up with great models and frameworks for action or guidelines, but showing how it could be put into practice, I think was what I picked up from there. So any questions, continue to put them in the Q&A. I am keen to get on to hear more from Anthony, so but we'll come back to some questions at the end. So Anthony, I'm interested in the whole of community approach that you take to your work. So I'm wondering if you could share with us how you engage with communities to reduce alcohol harm.
So I might, again, I've got some slides that I might run through to talk about exactly that process. If I can find them. Well, I had it open, hang on. Right, there it is. Can everyone see that okay?
Yep, and if you're just able to put it into full screen mode.
How's that?
Still seeing your slides.
Sorry. You can see the slides all right or not?
You can see the slides, yeah, it's just not to full screen.
Oh, it's not. How do I put it into full screen?
A couple of ways. If you go down to the bottom right, next to where you see the kind of the icons for notes, the fourth one along, is that, yeah, that one there should be slideshow. That should get you to full screen.
That work?
No, it's not. That's okay. We're happy.
All right. I'll just have to. All right. I'll just flick through it then. So this is. I'm just going to talk about hopefully you can see that okay. The slides okay there. But I just wanted to talk about a project that we did working with whole communities. So the idea here is to kind of just give you a sense of, you know, in drug and alcohol particularly, how you can, as well as working, you know, we tend to think about services and working with individuals, but how you can also think about working across whole communities. So this is a big project we ran a few years ago now, and it involved, put the slides down here, 20 rural communities across New South Wales. They're the 10 experimental ones. So we did a community level randomized control trial. So they were the 10 experimental towns, and each of those communities had a matched control community. And so we did a whole lot of interventions that I'll talk about in a second in each of those experimental communities, and then we compared the outcomes against their matched control communities. So as it says there, the idea was really around you know, moving, not just focusing on clinical treatment, although that was part of it, but really trying to think, what are some population level strategies that we could put in place to try to reduce consumption across the whole community. So, you know, in epidemiology, there's a pretty clear guy called Jeffrey Rose demonstrated this very robust and clear association between how much something is done in a population on average and how many people are likely to have a problem with it. So in this case, I think he used salt intake was the one he demonstrated this on. So the higher the average intake of salt across our whole population, then the more people are going to have, you know, hypertension and problems associated with salt intake. And so it's exactly the same with alcohol. So the higher the average consumption is in a community, then the more likely, or the higher the number of people who become alcohol dependent or have significant problems with alcohol will be. So if that's true, then one way to try to reduce the number of people who are highly dependent on alcohol in the community is to reduce how much the whole community is drinking, that average consumption. So we looked at whether there were some things that could be done to try to achieve that outcome. And then we looked at, you know, it's really just looking at all these discrete types of settings. So we did things with around random breath testing. We did things with GPs. We did things with hospitals and emergency departments. And the whole idea was to say, if we can get all of these groups in a community working together, can we show a reduction in alcohol harm? So we had 20 communities, as I talked about. We implemented 13 interventions in the end in each of the 10 experimental control communities. And then these are the things we measured at the level of the whole community. So we measured rates of alcohol-related crime, so using local police data. We measured rates of hospital inpatient admissions. We looked at traffic accidents, so alcohol-related traffic accidents. And then we did a community survey to measure consumption and perceptions of harm across the community. So this just gives you a sense of some of the interventions. So we went through a fairly intense engagement process. And, you know, we engaged with the mayors in this case, and we got all the mayors to agree to chair a group of key stakeholders. And then we went and presented data to that key group, you know, specifically in relation to their community. So here's your current rates of alcohol-related hospitalisations, here's current rates of drink driving accidents, etc. And then we worked with a whole group of people. You can see there, GPs, pharmacies, high schools, etc. These that I kind of wanted to flag, as well as just give you a sense of what some of these interventions were. If you look at these, the resource value, so this is not our time, but just what it costs to implement these interventions. And you can see they're all actually not that high. So I just wanted to, you know, I think an important thing is that we can often think, oh, unless I've got $1 million to do some big intervention, it's not worth doing anything. But I think this just illustrates that with fairly modest, you know, non-salary type budgets, you can actually do some quite good interventions. I'll just flick through a bit. So I just wanted to give an example of, you know, something that we did with emergency departments in the experimental rural community. So only 5 of them agreed to be involved in this one. So we just did it with those 5 emergency departments. And the real, we've talked a lot today about, and David highlighted as well, the kind of problem solving, the work that I've done with Julaine and others over time has really just been about how do we solve practical problems. And so the one in this case was people on emergency department saying, well, people come in here, they're, drunk, carrying on. We're really busy, so there's no way we can deliver an intervention in our emergency department settings. So we went away and thought about that, and we went back to them and said, well, would you be able to just, if we could come up with, a 3-item screening tool, would you be able to build that into your triage process, and then we'll do the intervention? And, after some negotiation, they agreed with that. But the idea was that the ED staff just asked those 3 questions as part of triage. We got the data a couple of days later, and then we sent out a letter providing some feedback to each of the people who had been in the emergency department who are intoxicated. And it's not, in principle, again, that was quite simple, but there was negotiating with the department at New South Wales Department of Health, because they were really worried that this would look like saying to people, oh, you shouldn't come into the emergency department, you've been drinking. So, it wasn't straightforward to be able to get this intervention up and running. But we got there in the end. So this just gives you a sense of what the feedback looked like. So, someone who said that they'd been drinking this much, had this many drinks. We then put it, this is something called an audit, or the audit 3. So it's the first 3 items of a very well used screening tool called the audit questionnaire. And we just sent them some feedback like this. Said, look, here's how much you're drinking. Here's how much, we've looked at national data on rates of consumption across the country. And we estimate that in your community, 82% of people drink at this level, and you're outside of that. So it's really just trying to give people, that sense of normalising where their drinking level is at. And this was the outcome. So it didn't cost us very much, as we talked about, to deliver this intervention. And the red bar is really an important one. So this is how much people reported, or the drinks, people reported drinking in the 6 weeks before we asked them. And you can see in the intervention community, the alcohol involved adherence presentations were much lower relative to the controls. That was a nice outcome. And then just to kind of give you, often we think, oh, we do these research projects, particularly I think in rural Australia, but we do these really well designed studies. Doesn't really make any difference. And this one, we had 2 pretty good publications from it. But really, the results have been picked up and have been used in all these various places. So the UK have used them in their policy documents on how pharmacists might go about doing screening and brief intervention for alcohol. It's been picked up by the European Monitoring Centre for Drugs and Drugs Addiction, and also in the RACP and the Royal Australian College of Australia, New Zealand College of Physicians. It's in their policies as well. So, as long as we're doing, I think, really, methodologically good quality work, it will get used. And I might just stop there. And I don't think there was anything else. I think actually most of the other ideas Julaine had covered. So I might stop there just to give people an opportunity to ask some questions. And I might just, as I finish up, as Julaine was talking, I kind of just scribbled down a couple of notes that it might be worth reflecting on as well, that I was thinking of as she was speaking. And I think one of them is about, early on, Julaine said, or highlighted that idea of, in a research group, it's really important to have different skills. So Julaine and I have worked together a long time. She's, qualitative and a social worker. I'm not. I'm a, quantitative psychologist. So she's a clinician. I wouldn't know how to run a clinical service to save myself, but it really works well having that mix of skills, I think, in order to get the best impact that you can. She mentioned with the craft project that we've taken a few goes at it now to try to get it right, and I think that's a really good point to pick up on, that you've got to be persistent. So things don't work first time. There's always going to be problems. It's trying to work through those problems in order to get some sort of research done. It's never straightforward. We talked about being really, one of the things Julaine and I are both really focused on is, how do we solve real world clinical problems? And that's why it's important that we work with clinicians and services, because we want to understand the things that are problematic from their point of view. And I've sort of flagged this a little bit, but I can't stress enough the importance of doing really high quality work, whether it's qualitative or, running cluster randomized trials, whatever the methods are. It's much more important to make sure they're right and we get, we're doing really good quality work than it is to worry about whether or not you're going to get a positive result. Once, if results aren't as positive as you'd like, then at least, it's because of the intervention's not right, or, there's something about the process that's not right, rather than it being something about your methods that isn't right. So it's, I think they're just, that, trying to make sure you're really getting the methods of what you're doing right is really important.
That's great, Anthony, and I like the fact that you show that some of those interventions that didn't cost a lot of money, or small interventions that can have a big impact, such as the brief intervention being picked up by pharmacists and others overseas. Now we're quickly running out of time. If there are any quick questions from anyone, I invite you now. Otherwise, we might have to answer them offline for the webinar, if I can indulge Julaine and Anthony in that. What I would like to say is this is such an important issue for our regional community. So thank you very much, both of you, for participating. And it's something that Manna's interested in. We don't have a specific research stream in addictions at the moment. So I invite anyone who's interested in being part of that to contact Liz at Manna, and we'll hopefully connect some like-minded researchers to continue that. So thank you very much. The other plug I'd like to give is to Manna's symposium that's coming up in December, and calls for abstracts are closing this week, I think Friday the 2nd. So anyone who wants to put in an abstract, time's running out fast. So thank you all for today. I think we're a couple of minutes, so if there's any concluding remarks, I don't think we've got any more questions coming through the chat. I might indulge with one more question. Given the Olympics is on, and we're celebrating our gold medals performances, to both of you, what would be a gold medal performance in integrating services or research in drug and alcohol? What's where are we reaching for?
Well, Anthony?
We could probably almost say this at the same time. Integrated mental health and drug and alcohol.
And certainly one of the comments in the questions there was about the difference in the UK, where mental health nurses have some training in alcohol and drugs, but that's not the case with our APRA registered nurses here, I believe. Something for further advocacy, I suspect, through both research and through our nursing cohorts.
Yeah, we'll keep working on it.
All right, well, I might call that a day for now. Thank you again, both Julaine and Anthony, and thank you for everyone in the audience for being part of this, and we look forward to seeing you at next month's webinar, where we'll be looking at the international position statement on working with rural communities in research. Thank you all, and
thanks,
bye.
David.
Thank you.